Well, good day. Welcome to this Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this final seminar celebrating the University of Waterloo's 50th anniversary. I can't believe that we've come almost full circle on this. I'd like to welcome our web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a real or virtual mic to you. A very warm welcome to our guest speakers, Professors Yuri Kogolovsky and Stefan Pantazzi from Conestoga College. I'd like to acknowledge our seminar series sponsors, Borden Ladner Gervais, McKesson, Healthcare Information Management and Communications Canada, and Smart Systems for Health Agency. We could not host these seminars without their support. Before we begin, I'd like to announce our new seminar series starting next year. The first of this series, which will be entitled The Many Facets and Faces of Health Informatics, will be on Wednesday, January the 16th. We'll have more information about this exciting series available to you shortly. As you know, this seminar series is in celebration of the University of Waterloo's 50th anniversary. The anniversary theme is Why Not? These seminars are dedicated to this theme and explores different why not questions related to health informatics. We've examined challenges on how we do things now in healthcare and look for new and better ways. This series started in January of 2007 and asked questions about our approach to medications, which is currently based on average treatment plans. It has looked at why we don't use cognitive science in handling the complex world of clinician-computer interaction. It also asks, why don't we make better use of knowledge translation to improve our health care? Why don't we use health informatics to create a better health system? How can we address clinician information needs better? Why are we not achieving e-health now? And how can we improve our record of patient safety? This wonderful series ends with looking at the crisis we face in terms of answering these questions and implementing the systems we need. The silent crisis of the lack of competent health informatics professionals. This is the question our educational institutions and government agencies must look at. So our agenda today is as follows. Dominic Covey, Founding Director of the Waterloo Institute for Health Informatics Research, will introduce our speakers. Yuri and Stefan will speak for about 45 to 50 minutes, and then we'll have a facilitated discussion. We ask that you hold your questions to after the presentation, and please signal to us so that we can get a mic to you so that you can ask your question. Just as a reminder, please position the microphone very close to you so that we can record the question appropriately. So now may I introduce to you Dominic Covey, who will introduce our speakers.
Well, it is very hard to believe that yet another year, but it has been a very interesting year. By the way, those of you who aren't aware, all of the presentations of this series are on the web, freely available, and you're welcome to look at those, and I know people are using it in their classes and things like that. We've had some incredible speakers here, and we're continuing that in the new year. In terms of our talk today, you've already got a little brochure here that talks about Yuri and Stefan. Maybe just a couple of things that aren't there. I met Yuri soon after he got to the University of Victoria, and both he and Stefan are graduates of the University of Victoria program, which has produced many of the best people in the field in Canada. It is an undergraduate program plus now a graduate program, and they're just examples of that. When there was the opportunity to bring Yuri here to the Waterloo region, I jumped at it, and very, very pleased that he accepted and came here, bringing, I think, a background that's unusual, both as a physician. You're a pediatrician, was it primarily? Pediatrician, and with an enormous background in health informatics. Yuri has, we were just talking today at lunch, and he actually comes from the area, it was former Soviet Union, now called the Ukraine, And we've discovered that he was not that far from Chernobyl, so it explains why he glows in the dark and in the light. So, Yuri, we're extrememely pleased to have you here, and I've been very interested in Yuri's work related to clinicians. And he worked with Jochen Mayer at UVEC, who's one of the people globally known for his work in clinical decision making. So, he has a really excellent background. Stefan Pataziu comes from Romania. Also, as I mentioned, came from the program. And the neatest thing about Stefan is what he writes. And I'll give you an example. His title of his dissertation, A Deterministic Dynamic Associative Memory Model for Concept Space Representation. Now, I don't even know what that means. I have no idea. A lot of what Stefan writes is similar to that, but it's recognized as some of the major contributions in the field. So we're extremely fortunate not only to have these two guys here to talk today, but to actually have them within relatively few kilometers of us, and I welcome both of you.
Thank you, Dominic. It's definitely a big honor and a pleasure to present for this series of seminars. And congratulations to the University of Waterloo on your 50th anniversary. So the thesis of our presentation today is that with the current shortage of health informatics professionals that we encounter in the field, there is a great opportunity to fill this void or this need through the degree programs at colleges. So in order to support this thesis, the presentation today will go through the following stages. At the beginning, we will talk about Conestoga College, which is Conestoga College Institute of Technology and Advanced Learning, or Polytechnical Institution. We'll talk about history of the program, short program overview, and then specifically we will go into some examples of how courses are taught in our program. We will talk about such applied aspects that we use in our program, such as what we previously called clinical practicum, and now we call health informatics field studies, and our experience with co-op work terms. Some information for current developments that we are going through in the program, some challenges that we encounter with during the 3 years that our program has existed, as well as I would want to show you the way program is reviewed and some testimonials from people in the field as well as from academia about the quality of our program. So first of all, Conestoga College. I can tell you that when I first time received the phone call from Conestoga College, I had to do some research about what's the name of the college. However, if some people in Ontario has never heard about this college, this is really pity, because this college has been based on the result of the government mandated and executed survey. It was rated #1 college in Ontario for 9 straight years. The college is now called Institute of Technology and Advanced Learning, and it's moved towards Polytechnical Institution. It has been established 40 years ago, so 10 years difference with the University of Waterloo, and we have 5 campuses, primarily in the area of Tri-City and some outside. So as you can see, we have a large number of full-time students and part-time students, and we have a large population of the international students that come in to the college, and then they continue education either at the college program or at the University of Waterloo. I wanted to, because we are talking about a degree program, I wanted to specifically emphasize the quality of faculty that work in the college. We have 124 people with a master's degree and 29 with doctorates, and out of these 29, 24 it's the people with the PhD. So college is not new to having Bachelor of Science degree programs. Some of these programs are in collaboration program, especially in nursing and in a business study. In nursing, it's a collaboration with McMaster University, and Bachelor of Business Studies is a collaboration with Windsor University. In addition to this, we have also the number of altogether six Bachelor of Applied Sciences programs, one of them in international business, some of these, five of these programs. So one of them international business, three of them in one of them in architecture, two in the area of telecommunications and manufacturing, as well as our program in health informatics. I wanted to emphasize that all degree programs at the college, they're co-op programs. So they were created based on this. So the programs, a little bit about the history of the program. The development started in January 2003, and one of the important parts that right from the beginning there was a program advisory committee. And this program advisory committee consisted from representatives from industry as well as academia. And this was in order to ensure that, first of all, the quality of the curriculum that would be developed for the program, as well as that people that program will produce, they will be exactly filling the need of industry. So, School of Health Information Science, University of Victoria, was taken as an example. And I want to tell that because both of us, Stefan and myself, we are coming from the University of Victoria, and we are feeling very grateful for the type of education that we received from University of Victoria, the oldest Bachelor of Science in Health Informatics program in Canada. And we learned a lot. We took undergraduate courses as well as graduate there, as well as we are very grateful to our mentor, Dr. Johan Meur, who contributed greatly to development of health informatics programs all over the world, specifically in Europe, in Germany, as well as in North America. And another document that created the basis of our program was the Pointing the Way, Competency and Curriculum in Health Informatics. And I will come to this document a little bit in a few slides to talk about how it was used and how our program was developed based on this document. So the program was approved by the Ministry of Training, Colleges and Universities. So proposal, I did not bring the proposal. You can believe that the reduced version of the proposal is a binder like this thick. The bigger what was submitted to the ministry is much larger. And I joined the college right after this in January 2004. We had a PQB panel review in June 2004, and the ministry approval of the program in December 2004. We started a year after this, in August 2005, with 13 students. And Stefan joined the college as a professor in January 2007. So this short history of the program. So if some of you don't know about Pointing the Way, I just decided that I would fill the gap, and I am sure that you can get document on the web as well as there are some copies available. First of all, it was created with support of federal government and HillNet. HillNet, it was one of the network of centers of excellence, which was health linkage application and linkage, health evidence application and linkage network, with a center at McMaster University and many participating healthcare organizations and universities all over Canada. And I participated in one of these consultations that was related to developing this document. Editors for document, Dominic Covey, David Zitner from Dalhousie University, Bob Bernstein from University of Ottawa. It was published in 2001. And the most important part is that based on this document, you can really create a curriculum for any health informatics related program based on competences. I would not go into details. If there are so many questions, I can answer how this document works. Dominic probably would be even in a better position to answer. But the most important thing, the document talks about three types of health informaticians. applied health informatics professionals, research and development type, and clinicians with health informatics competencies. So the next thing so where do we stand? Where do our programs stand with regard to these things? We are what is considered applied, we prepare applied health informaticians. We are a 4-year, full-time program with mandatory co-op component. We prepare people with a Bachelor of Applied Health Sciences, and we specifically focus on preparing people who are business process analysts. So what we combine, both of us coming from the university environment, as well as the documents that was developed pointing the way, is also emphasize those things. We combine theoretical rigor of a degree program, and this would be demonstrated, I can demonstrate it based on our curriculum, with a focus on applied aspects, and there are quite a few of them, and I will talk about them in more details. What I wanted to tell you is there are many definitions of health informatics. This one is mine, and it was created, I created it because during the presentation to the panel, of the ministry panel in 2004, there was a need in a definition, and I decided to create one just in addition to everything. I want, you can look through this. I will try to emphasize the main points. The main points is the following. Health informatics talks about benefit to 3 categories of people. We want to improve health, whatever definition it is, of individuals, communities, societies, first category. We want to improve functioning of healthcare. We want to make healthcare processes more efficient and that it will start producing healthier people. And the last thing, we want to assist in whatever level of decision-making, administrative, financial, clinical, that exists in healthcare. How do we, as health informaticians, do this? We have a theory and practice of managing data, information, and knowledge. And we do this using appropriate information and communication technologies. So this is a general focus of, and this is the definition from which we go when we teach our students. So this is a general overview of our curriculum. So we start with the foundation. I will go into, myself and Stefan will go into more details of each of these components. But in general, we start with the foundation module, which is 4 weeks, starting in the middle of August, and it's running to the middle of September, and I will talk a little bit more in details. Then we have courses in 5 major knowledge domains, which is health sciences, and courses here like anatomy and physiology, decision-making in, research in healthcare, governance and structure of Canadian healthcare system. We have courses in health information sciences, which is, we have 3 courses in health informatics, 1, 2, 3, health records, quality improvement in healthcare, decision support in healthcare. We have a large variety of courses in IT, and some of these, Stefan will talk more about these courses. We also have courses in business and management. We have course on economics, course on fiscal aspects of healthcare. We have course on project management, explicit course on project management. We have course on change management. We have courses on organizational behavior. So we prepare really well our students for this aspect, as well as courses on generic skills. And here, the most important part, this is why we consider that we really prepare people for a career, because we make sure that after graduating from our program, these people can work in teams, they can be leaders, they can really well not just write English stuff, right? But I will show you communication courses that we really teach them how to communicate. We have courses that called user training and adult education. So it's really about generic skills. We want them to be successful in whatever way they go after our program. Another aspect, more applied, is the clinical practicum. We'll talk more about this thing, and co-op work terms. So I know it's a very small print. Don't worry about stuff. Some of the things we will talk, some of them courses. If you have any questions, we would be glad to answer. It just shows the representation of different components in our program, different knowledge domains. And it also shows where located our co-op terms. And I want to emphasize one thing, is that if you look here, you can see that our first co-op going after first year. And I will talk how we prepare, or we will talk how we prepare our students to be ready in February, starting our program in August, September. In February, go for interviews for this time, and they are successful. Okay, so the next thing I want to talk about the foundation module. So the foundation module is practically we try to make sure that our students, before they start, so it's 4 weeks, 2 weeks before Labor Day, 2 weeks after Labor Day, and we try to make sure that they are ready to study on the degree level. So what we do, we teach them biomedical terminology. We make sure that they're able to use computer application on a level that is sufficient for them to take IT courses. We explicitly do the following. We have presentations, each one of them 2 or 3 hours, where people explore intercultural communication. We have some experts, excellent experts in this area at the college, as well as we do true color testing. And if somebody not familiar, there are different types of testing. We want to make sure that these people know how they work in groups, they know about their learning styles, they know how they communicate. True colors is one of them. So when they later on, we combine people and let them work in groups, they understand pros and cons and strengths and weaknesses of each member of this core, of their group. We do, and this is all related to the group dynamics course, where our students are exposed to, it's a full course, 45 hours, where they work in groups, and practically after this month, they are ready to work in groups for every course. And we are using in our courses right from the beginning, from the day one, they work in groups. I will talk about this as well. So another thing that we do, we introduce them to co-op. We talk about site visits and dress codes. Why? Because we take them on site visits during this foundation module. So where do we take them? The site visits, we take them one day. They go to, and together we go together to these places, who all of them, they have been great supporters of our program. So we go to Grand River hospitals, and they have a presentation about the type of work that people do in health informatics. Who is working, what type of skills and knowledge you need to have in order to be successful in health informatics. Right after this, the same day, we go just across the road to Waterloo Wellington CCAC, where they demonstrate their community health information system, CHIN, and they talk about the business of CCAC, and they talk again about the same things. What are the career opportunities? What are the skills and knowledge that people need to acquire in order to be successful in health informatics? Another day, we take them for full-day trip to Toronto. We go to University Health Network, half a day, and then we take them to Courtyard Group. And so this way they're exposed to another thing. It's an academic hospital as well as consulting company. And the third day, we take them to Aqua Healthcare here in Waterloo, where there is a presentation for 2-3 hours. And every time, this is what I want to emphasize, every time when we go, the students have list of questions that I give them, because I supervise this process. I give them a list of questions, and I say, you have to ask questions if people don't give you this information. And the questions are, what is a typical day of health informatician? What is a typical week? What are the projects that you are working with? What skills and knowledge do I need to have in order to be successful? What are the opportunities to get a job or co-op in this environment? And what students do after this? They have to write reports. And these reports, and again, we are talking about first 4 weeks in our program. They have to write reports. These reports are marked right from the beginning by their communication faculty as well as by me. From both sides, they need to address these questions. And what students commented is that such visits bring their future job to life and inspire them to learn harder. Because if you work with health informatics education, you always know it's so difficult to explain who health informaticians are and what they do. Our students, after 4 weeks, don't have these questions. They're very clear about things. They can tell you, this is what I think I want to do. It might change, but at least they know that what we are doing is towards them getting a career. So now I want to talk about examples, some examples how our courses are taught in our program. So we will do like this. I will talk about Health Informatics 1 and Health Records, the courses that we teach during the first term while students are in the program. Then Stefan will talk about Health Informatics 2 databases, and then I will step back and talk about communication courses and user training and adult education. So, it's an introductory course. Health Informatics 1 and Health Records, first term, people just started program, introductory course. I experimented with the different ways of delivery courses, and one of this way was integrating both these courses. I will tell you a little bit. If you have more questions, I will be very glad to tell you more. So, if people teach, the way I decided to teach health informatics is to teach using this textbook, using case studies. If you are not familiar, it's a great book by the group of authors, which is one of them is Nancy Lorenzi. She was a she's a great lady, and her husband who passed away, Bob Riley, they together wrote this textbook. It's a case studies from all over the world. And they talk about successes and failures in health informatics and type of work. And some chapters of the book, it's called Transforming Healthcare Through Information. Some chapters of this book, they talk about change management, system implementation, organizational change, economic leadership. The students get, we practically talk about case studies. They get, after we get, sorry, I have to be clear. At the very beginning, we spend some time talking about definitions of health informatics, type of work health informaticians are doing, connection to other disciplines. When it's done, we start working through case studies. And what I developed, and I want to show you, how case studies are analyzed. So we practically, and I tried from the very beginning, that all students, they need to have clear picture. It's very, they have to see what are the problems in healthcare that the case address. And there are different types, and we usually talk, it's usually clinical, administrative, financial, technological, organizational. So they have to see it even before the case started. They have to understand what are the issues that the case is trying to address. They talk about the way health informatics has to contribute to resolving these issues. And then they look in the things that went wrong in the case. And then they discuss what are the possible solutions to the things that went wrong, and how, what can we learn from this case, and what do they, as health informaticians, need to learn in their education in order to be successful if such cases would appear. So practically, what I'm telling now, it's a little bit different from, I taught this course in an integrated format for 2 years. I'm teaching it a little bit different this year because of our students are very busy. They have 7 courses in their first term. It's a very heavy load. But the thing is that when they analyze these cases, they had to present these cases to the class. So practically first week in the classes, they write a group formation report. We subdivide them in groups of 3, 4 students. They have to write a group formation report. In the group formation report, they have to analyze, tell us what type of case studies they are going to present to the class and why is it important. And then they produce Gantt chart and responsibility matrix. And we follow up. They had to write 4 progress reports. So we are talking about first term, 4 progress reports. They have meetings with me where I function as a project manager, and they have to produce agenda and minutes. And I work with them so that they be able to present twice during the term different chapters of this book as case studies to the class. So students in the first term teach case studies and being evaluated based on how they teach. And at the very end, they produce reports. If you want to look at this, these are examples of case study portfolios that our students produce at the end of this course. So I will stop here, and if I will let Stefan talk about other courses, but if time would permit, we'll talk more. So, sorry. My fault. You go. Yeah.
So great to be here, and thank you for the invitation, Dominic and Shirley. Great opportunity. I'll continue now the discussion about the courses we offer in this program, and particularly the ones I'm teaching. This is one of them, this Health Informatics 2 course, and it steps back from the case studies that Yuri is teaching in the Health Informatics 1, and then takes a more theoretical stance and view on what health informatics is. So we touch on fundamental concepts of informatics, such as data, information, and knowledge, and systems, what is an information system, and so on. Then we knowledge representation issues, such as terminologies, and why do terminologies, particularly why do terminology systems, why we will never have a unique terminology system. So we take the opportunity to put everything in a theoretical perspective and figure the fundamentals. Why are things done in such way and not other way? We touch on different information systems and types of information systems and theoretical issues. This is a great course to teach, also because of the textbook that I'm using. I'm using this particular textbook, which was new to me. So it is a learning experience for me as well. It is a good textbook, and I recommend it to anyone that might want to learn about health informatics. We also have the students write a research paper at the end of this course, and as Yuri mentioned before, we're trying to integrate teaching the courses. So this research paper is going to be actually the way to write it, and everything that's all the logistics of how to get it's actually a primary research paper, so people would have to get their own data. But all the logistics of learning how to do that those are being taught in the communication course, which runs in parallel with this course. So it is a good integration, and I think it makes things a little bit more manageable for the students. Sorry, I think I stepped. I moved on too fast. The other courses I'm teaching are the database courses. Since I started with this program, I had the opportunity to teach and develop some of the all the database courses that we teach. Not develop all, but teach all. So we're slowly building we have 3 of them, and we're slowly building increasingly more complex concepts from Database 1 course, which touches on fundamentals, and then we move on to SQL, which there's a course that covers comprehensively all the SQL programming language, and also I take the opportunity to teach some theoretical concepts there, relational algebra, so people can put in perspective why SQL is that way and not other ways. Then everything culminates sort of with the project-based course, which is the third database course that has to do with barcode technology in healthcare, particularly with drug management type of applications, which lend themselves very easily to barcoding. And I also take the opportunity in this third course to teach the XML-related knowledge. This is an example of the project. This is an application that students are supposed to put together. It's just a simple project where you would have a drug management system, basically a drug. We have a patient with some demographic data and then some orders that are supposed to be administered to a patient. Everything is barcode enabled, so we have a barcode scanner, and then people are supposed to create these barcode enabled reports that allow the workflow of finding the patient in a record, then scanning a patient bracelet, and then administrating one of the doses for the same drug, because each drug might be administered in multiple doses, so we have unit dose labels. This is an example of the projects we play with during this course. So I'll step back and let Yuri talk about the communication courses.
Thank you, Stefan. So in regards to communication courses, we figure out very fast that the number of communication courses that originally was in the program and their positioning was not sufficient for students to demonstrate their communication skills during their co-op work terms. So we made some changes, and we planned these changes together with the communication faculty. We had some meetings between health informatics faculty and communication faculty, and current situation is that we have 3 different communication courses, and on the next slide I will show you what they are and what they are trying to achieve. In general, the goal is that we try to develop oral and written skills, and every assignment is connected to health informatics. The example is that if they have to write a memo or a letter, it has to be connected to health informatics. If they do a research of the industry for companies, for example, another assignment, they have to research industry to come up with the 3 companies that they are interested in. So this is the example. They have to do this for communication course, but health informatics is involved. Very often, evaluation is done by both faculties, as well as we put a strong emphasis on intercultural communication. When we talk about intercultural, we don't just talk about people coming from different cultural background, like different countries and different cultural background, although it's very important because what we look in Canada in general, right? But when we look at healthcare system, we know that there are different cultures. Culture of people who are doctors, culture of people who are nurses, culture of people that work in IT, culture of people that work in management. So, but this way we make our students aware about these differences. So there are 3 courses. One of them, first one in the first term, so they go first, second term, then there is a co-op, and then students come for advanced communication for next term. So, foundation for communication for health informatics. The focus here, after to develop writing and presentation skills. Based on communication theory and using and citing secondary research, our students have to produce emails, memos, minutes, letters, and job search materials. It's the first term. The second term is a professional communication, when students need to demonstrate conducting and using primary and secondary research and produce short as well as formal reports. Second term. Then they go on co-op, they test how it's efficient, do they know enough of things that we taught them. They come back from co-op, and then we go into advanced communication for health informatics. It's still about presentation skills, still about writing, creating, but now it's specifically creating workplace documentation, user manuals, proposals, system and business requirements, documents, and we are also teaching them skills that they need to conduct successful meetings. Another thing that it's a course that we are teaching this year first time. It's in the third year. It's user training and adult education course. It's practically because our students very often need to work with different groups of people to be able to teach them these things related to new technology or new concept. So we develop abilities to conduct needs analysis and make sure that the trainings that our students develop, they target to specific groups. And these delivery modes have to be different. This is what we teach them. They have to be in class, online, in a learning center. And again, we make sure that they know about different learning styles and that they understand the difference between different institutions and different cultural expectations. So another thing that I want to tell you, this is about our field studies, what was called previously clinical practicum. In the second term, 1 day a week, 1 day a week, our students go to healthcare organization. We arrange this. I supervise this practicum for 2 years. This year it would be the third year. So we find healthcare organization. Usually it's a big hospitals. Our students work for Grand River, Cambridge Memorial, Guelph General, and any other organizations that we are able to find. And for now on, it's going really well. So the work during this day is related to health informatics. And they write weekly progress report, which at the end of the field studies, there is a presentation. It's kind of a celebration. Each student presents in addition to their written report, big report about field studies, they also present to their peers, as well as faculty and preceptor and program administration. They present the result of work that they did during these field studies. Another important, it's a co-op component. Co-op component, we have 4 co-op opportunities, 3 out of them mandatory. We really, as you remember, I said the first co-op opportunity after first year. What does it mean? It means that they have to be ready to apply for jobs and go for interviews in February or March. So what do? We prepare them. The communication course in the first term prepares them. They already know how to write their cover letters and their resumes in the first term. The second term, first 8 weeks, co-op course on how to deal with securing co-op placement. So our employers to date are great supporters of our program: Alpha Healthcare, University Health Network, CIHI, Practice Solutions Software, Waterloo Wellington CCAC, St. Mary General Hospital in Kitchener, Medicalis, People Care, Whitby Mental Health, Grand River Hospital, 3M Canada. 3M Canada in London, until this year, they never hired a student from the college. A student from our program was the first student that they hired because of her skills. Salary between $2,300 to $2,600 per month. The program is constantly being reviewed. It's reviewed through the Program Advisory Committee, which is a representative from the industry and academia. We constantly have student feedback, formal and informal. And one of the things, it's KPI survey. And if you know about this, it's a government-mandated and government-executed survey that looks at the quality of education quality system in Ontario. We have faculty consultations. We get co-op employers telling us what they like or don't like, as well as a review by Dr. David Zitner from Dalhousie University, he came from after first year of our program, after second year. Next year we will have him after third, and then after fourth year program, he does the detailed review of our courses. He talks with the faculty, he talks with the student. So current development, I will let Stefan now to talk about this current developments, and then I will step in again. So please.
So current developments. This is an area that has to do with curriculum and looking at different curriculums from different programs. Being in the positions that we are, where we actually looking at increasing our student numbers, we're looking at the programs and how they match. They're so-called affinity programs that might match some of our curriculum. Now, one of those programs is Computer Program Analyst, which is a diploma program that is offered in our college. And a natural thing to do would be to develop an option for such diploma graduates to actually enter our degree program with advanced status and then complete our degree program. And that can also be done for health information management diploma graduates, which exists in many colleges in Ontario. And because of our component, our IT component in our degree program, they typically would, if this were possible for them to do, then they would enter in a different year. But nonetheless, we're working on that. And part of that work is also a certificate in Foundation of Health Informatics, which could be offered to health professionals out there that might be involved in health informatics projects just by nature of being there in the field and being involved with such projects. And that could be offered to them on a part-time and full-time basis. This certificate is also the basis of the degree completion options, because such diploma graduates might actually have to do a pre-degree work in order to get the advanced standing status. So the reason I enjoy working in this area is because you'll see right away, as I will explain it to you, it touches on fundamentals, one of the fundamental problems in informatics. How do you match conceptually information? In this case, not health records, but curriculum. Curriculum, and this is actually was made a little bit easier for me because colleges, being excelling in teaching, they joined the idea, or they adopted the idea of outcome-based curricula. And what does that mean? Is that you have a program, and that program has some knowledge domains, that we had the 5 of them. In those knowledge domains, you would have typically some courses associated with each domain. For every course, you would have a course outline that would have a description of the course and outcomes that typically go after. Upon completing this course, the student would be able to, and then there is such a thing as a verb, which could be apply, use, calculate, and some very well chosen verbs, and then a topic. And that makes it easy for such an analysis, provided you have the same data structures. So it lends itself to database. Like I said, I'm teaching database, so I'm comfortable with doing everything in databases. So relational database come naturally to do this work. And example of how you would match this and why is it a fundamental problem in informatics is, for example, you need to match the use of concept of probability with maybe other outcomes in other programs, in other courses, such as apply descriptive statistical theory to healthcare data, calculate statistical measure. These are examples of matching conceptually areas or concepts. And this is a largely unsolved problem in informatics, but something that it was very dear to me because I did work in that area. Another thing I am involved with, by the way, I didn't talk about this matrix here. This is an example of how you would, the end product of such an analysis called gap analysis. You have on one side, you have a program, a curriculum of a program at course level, and on the another side of the matrix, you have another program. And the gaps and, of course, the matches will define what the gaps are. And this is where how you would determine how much a program matches another program, and then you would determine what courses people need to take in order to enter a different program. So the methodology is pretty well standardized. Only that part with matching conceptually the knowledge, that still is outstanding, and it's subject to research, but can be done nonetheless manually. Another thing I'm involved with is the program website, which I try to put together. It's work in progress forever. So I use a simple content management system that allows me to do clean things and functional things. I worked very hard to make the URLs that we have, so all our knowledge is actually accessible through URLs that are very clean, very standardized. And we have a simple navigation means in this website, and we found that our biggest attraction to having hits for this website is actually maintaining a repository of job ads, which we anyway get as professors, we anyway get in our email. So it's just a matter of putting these on the website in some form, and then Google and the other major search engines, they find us nonetheless. So, and people will find us looking for jobs, and they'll know we exist. This is an example of how the website traffic stats. I keep looking at that, though sometimes it is confounded with my working on the website. Being a content management system that allows you to edit it in place, then that adds up to the traffic, and I didn't take the time to actually subtract me working on it. So I think those spikes in March and August, it's mostly me, the page views. Anyway, so to get an idea that what the traffic stats are. Another thing I'm involved with, because I also am looking forward to doing some research, is developing a health informatics lab. And this will, there are some areas we could do work. And one obvious one is usability engineering. We could have systems that we could test and think aloud protocols now only require a camera and a computer, basically, and the person that tries to use the system. So that can be done, and we have the space to do that, and we have some of the equipment. The other things I'm looking forward to doing is some more advanced application with mobile telepresence and telehealth and other robotics maybe. This is in a college. We are fortunate to have this environment where we have the engineering and tech degrees and programs that we could do some cross linkages with them in this area. Another area that is just maybe because of my personal preference, I would like to put is digital signal processing. And we also have some equipment to do barcoding, and we're looking forward to getting RFID-enabled applications and wireless communication. I think I'm going to stop here and let Yuri talk about the challenges. And
thank you, Stefan. I want to emphasize that dedicated Health Informatics Lab, the primary goal is to introduce our students to the applications that are out there. It's a primary goal. Because we take, in our program, we take a very pragmatic approach. Our first question is, do we teach people from the theoretical and practical point of view what they would need in order to have a successful career and then expand? If they want to go to graduate school, it's great. We want to make sure that they are ready for this. If their goal to be CIO or to be director of IT or whatever, we provide support for them. So when you see all these applications, they're not just for us to play with. They're there to be able for students to see what health informatics can do with healthcare in healthcare environment. Okay. So our challenges. First of all, it's a public understanding of health informatics. We discussed this just before during this mini seminar. It's very difficult. It's very difficult. It's difficult for people to understand. However, I think that with the time and with the different efforts that you're doing from university side, that we are doing from our side, from more information that appears in different press releases, in newspapers and magazines, I think that health informatics will be known. The second thing is degree promotion. This is what we are doing constantly. Going to schools, talking when counselors come to the college. We have, even this week, we have few events for parents and for students. Next week we have Explore Conestoga. So we are constantly involved in this because we need to get people to the industry. Industry is telling us. I was when Eric and I we were in Toronto and coach this executive forum. This is what industry says: give us people. We want people that can make difference. And who makes difference? People who can take our theory and implement, do things the best possible way into healthcare, improve healthcare, help healthcare professionals, improve health of individuals and population. We have, if you look at our admission criteria are extremely high. The average for admission to our program is 75 out of the average 75 with 6 U-level courses. English, grade 12 U-level, 1 of math, grade 12 U-level, and 2 out of 3 sciences, physics, biology, or chemistry, and plus 2 courses which is either U or M level. It's extremely difficult for a lot of people to get. We are trying to make sure that we support high quality of the program, but we also sometimes we make these people to do some hoops and get them between 70 and 75, but we have to make sure that people that are coming to the program, they're still good students. And so far, this was the case. So I want to talk about our students. So our students, inspiration for us to develop and continue with this program. Their success is our success, and their learning is our learning. So we learn from them, they learn from us. Total, in 3 years, we have 27 students, age range from 18 to early 40s, and previous experience. We have approximately, I would say, 25% of students from high school. We have up to 75% of people with the previous university experience, either 1, 2, 3 years, sometimes degrees, university degrees. And we have quite a few people with extensive work experience. We have both males and females and diverse cultural background. Quite a representation. So I would like to finish, at the end of our presentation, I would like to finish with a few quotes from people that have our students for co-op as well as from people from academia. So this is the quote from Erkan Akuz, for Chief Technology Officer from ACFA Healthcare. Conestoga Healthcare Informatics program is extremely important for us, since it is one of a few programs in Canada which aims to graduate professionals in an extremely promising field. We are very excited to employ some of the first graduates of Conestoga Health Informatics program, which enables its graduates to be efficient in HI domain the day they finish their education. The first co-op, we had 4 people working for ACFA Healthcare. Some of our students continue working part-time also for some of the organizations that they did co-op. And I told this story before, and I can repeat. One of our students, after first year, she came back from her first co-op, and she said she worked for a company, in a regional company, and she said, you know, these people told me, we know that you probably would not agree, but is there any opportunity for us to convince you not to go back to school and continue working for us? So The next, it's from Brand Gingeridge, Chief Executive Officer for People Care Incorporated. The work experience component of the Health Informatics degree program at Conestoga College has been extremely helpful for People Care. Shortly after submitting our job posting, we were able to select from a number of extremely well-qualified candidates. The student completed projects our staff would not normally have had time or the experience to complete. We were able to complete our project at a very reasonable cost given the high caliber of talent utilized. I would definitely recommend the program to others. And last but not least, I told you that Dr. David Zitner from Dalhousie, he is coming every year to do a review of our program. This is what he wrote. After the first year, he wrote some endorsement of the program. This is what he wrote just after coming to review our program for second time. He said, our graduate program at Dalhousie, our graduate program executive committee looks forward to receiving applications for graduate work from qualified graduates of the Conestoga program. The Conestoga program, as it exists, will graduate students who will fulfill a vital role in Canadian and international healthcare. The program at Conestoga maps well to the applied informatics curriculum. In addition, the Conestoga program has a variety of courses that will contribute to the overall intellectual and human development of Conestoga students. I wish you well as the program proceeds, grows, and thrives. And this coming from somebody who is an editor of documents pointing the way, as well as a director of medical informatics at Dalhousie University, a person who has been with health and medical informatics in Canada and internationally for many years. We are really thrilled, and we know that we are on the right track with our program. So this concludes our presentation. Thank you very much again for inviting us, and we would be glad to answer any questions or comments or anything. Thank you very much.
So we have time for questions and comments, and from anybody, just let us get you a microphone to you. I want to start out the questions. You guys both went, maybe you could each comment, to the University of Victoria. You went through their program, you came here, you've created a program, and then you've been working in it for a couple of years now. How do you compare the two programs? What do you see the differences are, the strengths of each program are compared to each other? Can you reflect on that?
Yeah.
I think you're in a better position.
So
he's older than I am. So.
Well, this is what I want to say. I want to say a few things. First of all, I have been with the University of Victoria from 1995 till end of 2003. I taught at the University of Victoria from 1996 until the end of 2003. I think that the program there is a great program. Excellent. I took undergraduate courses, I took graduate courses. I think it's an excellent program, and I am very grateful for all the learnings that I personally got there, and all the mentorship from Johan Moore and all other professors. Like when you look at the people there, like Dennis Proti, world-famous expert in electronic health record, like Johan, who did wonderful work, Andrei Kushneru, Francis Lau. These are all people, great people. Now, what I want to say, that you remember these circles that I showed you. In any health informatics program, you can see areas that would relate to healthcare, to management, to IT, to generic skills, and to health informatics. The emphasis is different. So, but the thing is this one, in health informatics, every program would create graduates that would fit really well, as long as the program is driven by the feedback from the industry and academia. I can say we have our own strengths. They were built based on our experience working with the University of Waterloo and based on what in pointing the way. We are a little bit different, but the goal is the same. So my comparison would be, we fill the niche, they fill the niche, we do great work, and healthcare would be better out of this.
Can I add something? I think that at some point it is difficult to compare exactly the two programs, because one is university-based, where students will typically choose some of the courses they have, while we have a set of courses that everybody gets to take and go through. We can debate for a long time which model works best and so on. One thing is for sure, we have in this program the opportunity to actually unify the curriculum to something that is really coherent from beginning to end, because we're in control of it. Unlike the situation where different courses would be taught by different places in a university, where you have less control over that aspect. So in that respect, I think but it's also different to compare, also because I didn't take all the UVic courses, and I took only graduate studies there. So that makes it even more difficult. Like Yuri said, I think health informaticians are so broad in their strengths and weaknesses, and it would be a pity to just say that some are better than others. We all have strengths and weaknesses, and building those is probably the best.
While she's giving it, I'll ask you another question to get the microphone there. You've given us kind of a broad understanding of the backgrounds of students, but you must have learned even so far which students fit better with the program versus not so well, which you wished had started somewhat differently. Do you find all the students to be of similar levels of preparation emotionally, intellectually, and so on? Can you give us any idea about what you've learned about your students so far and how you might in the future adapt your program to those students?
I have been right from the beginning, right? So now I can see our 3 years of students progressing. I want to say that one of the good part is that, first of all, we are working right from the beginning, right? And the college, because we are not a too big organization, right from the beginning, we coordinated work between different faculty members. And really, if I know that one of our students having troubles with any courses, I can easily, as a program coordinator, easily make sure that the students, the concerns of the students would be addressed. So this is one thing. The second thing, we have small classes. So our class is not more than 12, 13 students. So we can really address concerns of the students. I can tell you that definitely, it's difficult. I think that our high school students do as well as people that went through the university. And I think that it all depends on the maturity of the student. However, we do a lot of work in supporting and nurturing students, because we know their strengths and weaknesses, and we want them to be successful. We help. We constantly help. We don't just discard people. We make sure that they're moving in the right direction. So I cannot say, I think that everyone can be successful if they're determined that this is what they want to do.
Let me push you a little bit on that. You must have one student that stands out in your mind as having done extremely well, found it a really great experience, and other students that have found it somewhat less so. They've had difficulty, had problems. What's the differentiation between that type of students? Or, again, are all students almost identical? I just have a hard time believing that. That's what...
Well, no, I'm not saying that they're identical. What I'm saying is that when you have a small group of students, and when you're really close with them, you see that, I don't know, maybe it's coming from my background being a physician, right? You don't have excellent children. You don't have excellent children, you don't have excellent patients, right? You always have to work. So we help them. We constantly help them, because we know that their strengths and weaknesses, if they're determined to get somewhere, we have support for them, right? The only thing, they need to come to us or to be willing to do work in growing. We have some examples of doing this, helping and seeing how people change during this type of work, right? So I don't want kind of say this would be better, this would be worse, because it's not. It's not true.
I can second that. It's not the case. We have examples of students that are mature and are doing great, and we have also examples of students straight out of high school that are doing excellent. So to simplify in saying that something that where they come from makes a big difference, I don't think it does.
Good afternoon. Very interesting program. Thank you very much. My question is about your vision. You talked a little bit about using health informatics to improve the health of people, individuals, communities, and populations. And I was just wondering from, based on the research you've done with your program to date, where do you think the biggest hole is right now in Canada, in Canada's healthcare for health informatics? Would it be in individual focused programs or communities or populations? And any comments you may have. Thank you.
Well,
I'm not sure I follow the question. So you mean within health informatics, what would be the application in most need of professionals?
Yes, and the focus for those professionals.
Well, I can start talking about this. Just the other day, we had someone talking about the architecture of electronic health records. The number he mentioned or cited from somewhere about the number of professionals needed because of this initiative for pan-Canadian EHR, it's about 37,000. So I would say that would be the biggest need if I were to choose something. So you have any other?
Yeah, I think that probably the highest impact is the area of primary health care. Just because of the number of people that get into, probably two. I would say two. One of them would be the things related. No, now that I can think, it would be three. So the first thing is probably the patient education. I think this is the biggest thing, because based on the number, and again, I'm talking about the percentage of population that take care of themselves or make some type of health decision that maybe come into the encounter with the GP, only with primary health care, right? And then they have to follow their prescription, or they have to change their lifestyle, their diet. So this is one of the things. This is a very important part. The second part, I think that it's primary health care, because of this is the kind of the functions of the healthcare professionals, the gatekeepers to the secondary and tertiary health care, as well as just the number of visits that they have per year, a number of times that they can spend with every patient. So the amount of pressure for really good information on which to base their decisions and to steer people into the right direction for their decisions, right? This is really the biggest impact. And the third, I think, is things related to public health, and especially things that we know with such things like, for example, SARS epidemics, right? Or things related to the problems with when we discover things like viruses having adverse effects and things like this, right? So we have to make sure that areas where we can have the highest impact is probably prevention, prophylactic, right? To making people healthier rather than dealing with them when they're coming already on the level of secondary and tertiary care. So this is what I would think.
I can imagine even more areas, but one would be adverse drug events and decision support in that area. That would be a good area to work in because it's high impact and also is in need of such work, decision support. So it's been proven to work. Health informatics, one of the success stories of health informatics.
Thank you very much for the presentation. I found that very interesting. I just want to clarify something. The number that I've heard tossed around is that we currently have a shortage of about 2,000 health informaticians. To hear it's 37,000 is exciting and scary, and it sort of leads to my question. You mentioned you have an enrollment of 27. Is that a total enrollment across all of the 3 years? I'm a graduate. Can I call myself a graduate, Dominic? I'm an attendee at the boot camp that the Waterloo Institute offers. And one of the things that I believed to be true from that boot camp was that if somebody came into the process with strong IT chops, that through the boot camp you would be able to see in what context those could be employed. And one of the things I found most useful coming from a background in another area was to see where the things that I did know how to do could be applied and help the cause in health informatics. I was surprised to hear the number 27 as your total enrollment, because that seems to be low in the face of what I see as a real dangerous shortage of health informaticians in Canada, because from the folks that I'm working with, usually on EHR level projects, pan-Canadian EHR level projects, one of their significant risks is that they are not going to be able to find the staff that they need to succeed with their endeavors. Why is your enrollment so low?
It's a good question. If we could have the answer to that, the enrollment would not be low. So,
why do you think your enrollment is low?
So, yeah, I can address some of that. Partly it has to do with population understanding of what health informatics is. It is a new concept. It's not embedded in popular culture. It's not like CSI, for example. If I say CSI, everybody knows what it is because they see it. They know. If I say what a firefighter is, if I ask what it is, then they know. So health informatics is pretty new. Let alone that it sits somewhere in between two major area of knowledge, which is IT and healthcare. And that makes it even more difficult to explain what it is. I find it always difficult to explain what an interdisciplinary program does. Why does it have to do both? Why not doing one very well? Sort of that kind of mindset.
In the session beforehand, people said we should make it more sexy and we should do all kinds of things. And so we actually last year had a lot of fun with this, and at one of our meetings we got shirts made up, which was very Canadian kind of thing. We had Get High, H-I, as the motto for the thing, and maybe that's it. Maybe we can have a CSI type thing. Call it Canadian Gold and we're home free.
Or our own TV series, yes.
One comment.
Yeah.
Just wanted to tell you, first of all, at Conestoga College, CSI stands for Conestoga Students Incorporated. just to be clear, another kind of informatics problem, right? When acronyms might not mean the same thing. Regarding the numbers, we have interest in the program because every 3 years we had 130, 140 applications through OCAS system. Out of this number, approximately 40 students had 75 plus. They could go into the program. But at the very end, what we got is approximately 13. We got practically every year 13, 12 students. 13, 12 students, right? The same thing. It is a difficulty. It is a difficulty, really. But I think that with the amount of work that's going on now, with the advertisement, with the boot camp, with the work that we do at high schools, talking about, like we are thinking now about addressing foreign trained professionals, maybe with the previous healthcare background. I think that we can catch up momentum. The good part is that if we compare now and 2003, we are in a better position. So let's be optimists and think that in 5 years we really can make these programs like booming.
The question was how many people have gone through the boot camp? Just about 340 in 2.5 years. The point, though, is in university, like our option program, in the computer science version, only had 2 or 3 people that ever took it. Applied health science up till this year had only a few. It has been an unknown area, and you're very correct in saying that. I think we have a lot of promotional work to do, but I think this year and next year will be years of change in terms of interest. Joe?
I can probably try and respond to some of your queries. I'm from Conestoga, so have some perspective on it. First of all, the number of applicants in the program ranges in the upwards of about 130 or 40. Admission criteria, as Yuri explained, are fairly rigid, and they're fairly strict. So it eliminates a pool of candidates which we don't think will cut through the program, because it's a fairly rigorous program. It's 6 or 7 courses a semester. Yuri has asked me to remove some of them off and on, and I say no, they have to work hard, and so on and so forth. So that's an ongoing battle internally. But they are very rigorous program, all degree programs. So that's one reason. There are two types of sort of cultural dichotomy in our country. One is a university bound and college bound. And frequently, students sitting in high school think of college as lesser than rather than different than. And I think that is a deterrent. Now, that doesn't happen in U.S. or in European countries. I'll give you an example. We have an architecture program also in degree. It's a different band other than Waterloo. Those students are freely accepted in the master's program in architecture at Cornell University, which is an Ivy League university in U.S. In fact, 2 of them were solicited very highly after the graduation, but they still opted to stay back and work because they were getting high 60s in salaries. But the point is that it would be hard-pressed to get a Canadian university to have that direct path, because there is that divide there, and it's a systemic divide right now. So that's, I think, another reason why some students select or not select college-bound programs, and let's be open about it, okay? Other thing, I think, and we have been trying to struggle all around, there is and I coined the word sexiness. I think we have a Conestoga Law and Security program. We get in thousands application in it. And guess what? Every second channel I flick on my Flickr as a cops and robber in it, there is no program like that on TV. I haven't seen a health informatics program,
Dr. House,
but House
anybody who's as bad a diagnostician as Dr. House needs health informatics.
See, I think that the thing is that House should have some health informatics in it, and that would be good. So that name recognition of the program itself, and we are trying to struggle with that name. I was asking some students earlier that, what would attract you if I came to your school and said, well, we have this program, what would you take? The last point which I want to make, again, that's our cultural thing in our country, and I think it's somewhat unfortunate. Parents, everybody says, go and get a education. They don't talk about go and get training. They say, and there is a sort of distinction between that. We are talking about applied side when we talk about training. So you get this hundreds of students going in general arts, and nothing wrong with it, But what happens, we have, for example, at Conestoga, we give a lot of post-diploma programs, which are 1-year package programs. And guess what? About 80% of the students are university grads in it. They've done baccalaureate degree at taxpayers' expense, and now they're coming there to get skills. So their education, which could have been 4 or 3 years, taxpayer has paid for 5 or 6 years now on it. Again, probably that's good or bad. I can't debate about it. As a taxpayer, I wouldn't want to have it, But again, it's a cultural thing here, and I don't know how and when we'll change those systems in our country, but I guess we are all trying to make some effort in it.
Well, I'm on a high here. Listening to this exemplary educational program, I learned a lot, and there's a lot of similarities in your thinking and what we're working on in our program. Sometimes the interesting things that emerge are the unexpected. I suspect both as physicians and the experiences your students have had, you've arrived at some intriguing research questions. Because they've introduced you to problems that maybe you weren't aware of. Can you talk for just a few minutes about any things that you've uncovered, the surprises that told you, this is where we need to take informatics?
Well, yeah, I could start because, well, the work we do now, being in a college and being teaching oriented, you have to work on curriculum and think about issues in curriculum. One of the crazy ideas I got, since you mentioned I should talk about it, I think there is a way to unify the curriculum so that it can be streamlined from beginning to end. I also started to think that there is a fundamental basis for this field, which many might debate. I think there is a possibility to actually write a textbook that has real fundamental mathematical concepts there that would make the basis of this informatics, whatever we call it. So those were things that were exposed to me through being exposed to the curriculum and to the program and to the students and to the need of the students. Some other ideas, I think they're related to just how fundamental how needed the way to represent information on a concept basis or conceptually crops everywhere. Everything you do, even in healthcare, even in curriculum, like I mentioned earlier, that idea crops up everywhere and it has to be solved once and for all. And by the way, it is, I consider, a fundamental problem in informatics. So, sort of.
I'm coming from a very theoretical research. Like my original research was on information retrieval, on like new methods of evaluation of information retrieval by representing semantics of natural text and comparing question answering systems and all other stuff. Since I came to the college, I realized that there are some other interesting things that you really can do. And one of them that I really feel excited about is that how do you teach very complex things to people that have limited background and bring them up to speed. So if I would, like, practically, I am doing research every day. I'm learning how to teach, how to create better curriculum, how to improve my teaching, how to explain things, how to experiment with new methods of delivery of the material. So this is my research for now. And because when you look at health informatics, it's practically how you create system thinkers at a very high speed. Because if people are not system thinkers, they might be successful, but they would be successful in a very small area. If we can make people system thinkers and being able to appreciate complexity, being able to communicate with different players, listen to them, and then influence the way policy or decision making is going in our health care, this is where we have the best impact. So for me, the question is how you create, in a very short period of time, people at such level.
We have, unfortunately, as we usually do, run out of time. First of all, Jake, I want to tell you I got worried about your getting high being the supplier of drugs. That's not good. And Yuri and Stefan, I'm really, really pleased you were able to come today. We've had a chance to work with these guys over the last couple of years, and it's been one of the bright lights of being around here is the chance to work with you. Hearing you speak about the program and go through it, although I've heard it before, I think you've done a really good job. Frankly, I think you're doing something for the healthcare system in Canada, and I hope it continues to go well and that you get greater numbers to bring into the fold. Thank you very much.
Thank you.
Well, I'd just like to wrap up. I see that there are some folders
here.
Yeah,
we have some folders with information about the program. And also on our website, there is more information that is available. Yeah, and I wanted to thank again for inviting us to present for this seminar series, as well as to thank you for coming and for this wonderful discussion. Because if there is an interest in health informatics, it means that we can make a difference in health care in Canadian or in any other country. Because every time when we open current publications, we see problems with healthcare, right? So this is what it's about. So thank you very much.
Well, I'd like to thank our speakers, and so I've got a small gift as a token of our appreciation. So Stefan
Thank you very much.
and Yuri. And I just want to wrap up by saying thank you so much for coming today. We'll start again in the new year, so have a very good holiday season, and we'll look forward to you in January. I hope you have a safe and happy holiday. And I guess that's it. So see you in January.